Hello guys, how are you? Hope you are doing well. Welcome to our channel Last Minute Pharma, and today we are here to discuss about the part 8, okay? This is the part 8 of the lecture, and today we are going to discuss about what are the factors which are going to modify, okay? What are the factors which are modifying the drug action? Okay, so till now we have already studied receptor families. We have actually entered the pharmacodynamic pattern, in that we have understood about the receptor, non-receptor mediated mechanism of action. Then we have also understood about the various receptor families and their mechanism of action, and how when the drug is going to bind to a particular receptor, and how that receptor is going to show an action. Okay, so today we are going to discuss about what are the factors which are going to help in modifying the drug action. Okay, so mainly this is a very important 5-mark question you are 100% going to have in the examinations. Okay, so you have to classify it. Okay, you have to classify what are the various factors which are there. First is the drug factor. So those factors which are related to the drug, what type of drug you are going to use, what is the route of administration of the drug. So depending on the drug parameter, we are discussing the drug factor. Okay, now the second one which is there, that is the patient factor. What kind of patient you are giving? Is it a young age patient? Is it an old age patient? Is the patient having any other comorbidities? All these which is there is going to come under the patient factor. So let's try to understand and break down into smaller units and making it easy for you. Okay, now first one which is there, that is the drug factor. So in the drug factor, first one is your route of administration. That means when the drug is given to the patient, in what route are you administering it? Are you giving it in oral format? Are you giving it in topical format? Are you giving it in intravenous format? So based on that, we are dividing it into two types. Okay, route of administration, two factors we are dividing it. One is the quantitative factor and other one is the qualitative factor. Okay, so quantitative factor means what? For example, let's try to understand with the example over here. If I am talking about the quantitative factor over here, you have to understand about the morphine. What is a morphine? It's a sedative drug, right? Morphine is a sedative drug. Yes or no? So this morphine which is there, when you are going to give it in the oral route of administration, you will be giving it approximately 20 to 30 mg. You are going to give it approximately 20 to 30 mg. But the same drug, when you are going to give it in the form of IV, we have to reduce the dose to your 10 to 15 mg. 10 to 15 mg. This is what is called as the quantitative factor. The amount of drug, the concentration of the drug which you are going to give. And why is that difference there? For showing that same therapeutic activity in the IV format, we have to give 10 to 15 mg. But whereas in the oral route of administration, we have to give 20 to 30 mg. Why is this difference there? This difference is because in the IV, we are directly going to administer drug inside the blood vessel. So in the IV pattern, if you talk, there is going to be 100% bioavailability. There is going to be 100% bioavailability. And because of this, in the IV concentration, if you see, when they are giving the drug in the IV format, the concentration of the drug is going to be less as we compare to the drug which is going to be given in the oral route of administration. This is what is about your quantitative administration. Okay, the quantity of the drug. Now, let us try to understand about the qualitative of the drug. Okay, the quality of the drug. For example, now let me give you an example of this qualitative format. Let's try to understand. There is a drug which is called as magnesium sulfate. Okay, there is a drug which is there. This is called as magnesium sulfate. So the same magnesium sulfate, when I am going to give this in the form of IV, when I am going to give this magnesium sulfate in the form of IV, then this is going to have an action of CNS depression activity. This is going to have CNS depression activity. But the same drug, if I give it in the form of oral route, okay, if I give this in the form of oral route, then this is going to act as a cathartic. This is going to act as a cathartic. See, it's the same drug, but quantitative. In a sense example, in what route are you giving? If you are giving it in the form of IV, it's going to cause CNS depression. See, again, though the drug is same, but based on different route of administration, the action of the particular drug will be different. Okay, so same magnesium sulfate when you are giving in IV format, it won't show cathartic activity. What it will show? It will show the CNS depression activity. But the same thing when you are giving the oral route of administration, it won't show your depression activity. It won't show CNS depression. But instead of that, it is going to show the cathartic activity. I hope it is clear. Now, the same drug when I'm going to give in the topical route of administration, the same drug, when I'm going to give it in the form of topical route of administration, it is going to show, it is going to decrease the edema in the site of inflammation. It is going to decrease the edema in the site of inflammation. So see, the same drug but just by different dose or different route of administration, we are having three different activity, and that is what is going to come under the qualitative factor. That's what is going to come under the qualitative factor. I hope it is clear to here. Okay, let's go on to the next topic. Now here is presence of a drug. Okay, now we are going to discuss about the presence of a drug. Now for example, when you are going to administer two drugs together, okay, already we have discussed this, okay, already we have discussed this in the previous lecture. I'm just revising it for you. So when you are going to give two drugs together, okay, either it might, you know, like increase the effect, okay, it might increase the effect or it might decrease the effect of a particular drug, okay, when you are going to give. Remember that example which I have given, right? For example, you are having a friend, you are making a company of a good friend who is going to be studying and all. So even you will start to study, right? So it's going to increase the positive effect. But same thing if there is a negative friend, okay? If there is a negative friend, so what will happen? Even you will start getting negative habits. So again you will be going in the negative way, right? So that is what is called as here synergism. That is what is called as here synergism. Then you are going to have here antagonism. Then you are going to have here antagonism. So presence of a drug, okay, when you are administering a particular drug A, then the presence of drug B is going to make a lot of difference. It might either cause synergism or it might cause your antagonism. Okay, I hope the presence of drug topic is clear. Now the last topic which is over here on the drug related factor, that is the cumulation. Okay. So what is this cumulation? What does this cumulation mean? See, cumulation is nothing but accumulation, okay? So for certain drugs, okay, for certain drugs who are going to have decreased rate of elimination, okay? For example, some drugs are there like your chloroquine. You are having here some drugs which are called as your chloroquine. Then you are having your digoxin. Okay, these drugs which are there, right, they are going to have comparatively lesser rate of elimination. Okay, so they are going to get eliminated the body from the body in a very slow process. Okay, it's a very slow process. So if you are continuously administering or if you are repeatedly administering this drug, then it can lead to accumulation of the drug in the body, and this accumulation which is called as, that can lead to the drug toxicity. Okay, so these all which over here you can see are the drug factors, and upcoming now we will be discussing about the patient factors and what are the different kinds of patient factors which are responsible. Like you can say your age, you can say your, you know, the condition of the patient, the comorbidity condition. Okay, so let us discuss about that and try to understand the patient factors. Okay, so now we are going to discuss about the patient factors. So now we have understood the drug factors, the various drug factors which are going to affect the factors modifying the drug actions, right? Now we will try to understand what are the patient factors which are responsible. Okay, what are the patient factors which are responsible for the drug to show their action. Okay. Now over here, the first one which is over here is that age. Okay, so age, see, already we have discussed majority of the factors. If you see, already we have discussed, like we discussed about the factors affecting metabolism, factors affecting rate of elimination, factors affecting absorption. So pretty much similar it is there. Okay, so let's try to correlate and understand. Okay, so when I talk about the age, so especially in the patients who are young age or the neonates, okay, so the liver which is there or the body organs which are there, they are not much developed. Okay, so the function of that particular organ is comparatively less if you compare with the adult, right? So similarly, if a particular dose of a drug you are giving it to an adult, the same dose of the drug cannot be given to a patient who is not, who is a neonate, because in adults our body is functioning very well, our liver is developed, our kidney is developed, but the case in neonates is not the same. So that's why we have to slightly reduce the dose. Okay, so we have certain dose calculation based on the adult dose. If we know the adult dose, we have to do some calculations and get the child dose or get the neonate dose. Okay, so for example, I will tell you, there is a drug which is called as penicillin G. Okay, there is a drug which is called as penicillin G. So this penicillin G which is there in adults, we are going to give every 6 hours. Okay, this penicillin G which is there, we are going to give to the patient every 6 hours if the patient is adult. If the patient is adult. But the same penicillin G which is there, we are going to give every 12 hours if the patient is a neonate. So if the patient is a neonate, we are going to give the penicillin G every 12 hours. Now why have we increased the duration? Because the rate of elimination of the drug in a child is comparatively less. Now why is that rate less? Because the kidneys which are there are not developed. Okay, so if the kidneys are not developed, the excretion will not be faster, right? As simple logic as that. So because the kidney is not that developed, so the elimination will be slower. So because of that, the concentration of the drug in the patient or in the child will be there for a longer duration. Okay, that's why in adult we are giving only 6 hours. Every 6 hours we are going to give penicillin G. But the same drug in neonates we are going to give every 12 hours. So I hope you understood how the age plays an important role. Now if the same patient is a geriatric patient, okay? Geriatric patient in the sense what? The patient who is in the oldest age, like after 50 years. So what is the problem with them? They are going to have many comorbid situations, okay? So what will happen? There will be some you can say of chronic liver diseases, renal impairment. So the drugs which are there, which are excreted by the renal route of administration, we have to reduce the dose, okay? Because what will happen is, if the kidney is not developed, kidney is not functioning well, there is renal impairment. So if you are giving to the dose of the adult, now what will happen? It will lead to the nephrotoxicity. It will lead to the nephrotoxicity in case of your geriatric patients. Okay, so the dose calculations are there. Some dose calculations are there based on the age, and then you have based on the body weight, then based on body surface area. So these formulas which are there are very, very important for your 2-mark question. 100% you will get. Okay, so first one is your Young's formula. So Young's formula, what is the formula? What is the main formula to use? The child dose which is there. Okay, the child dose which is there. That's nothing but age divided by age plus 12 into adult dose. Okay, now how to remember it? Simple thing. Okay, young in the sense, when do you say the person is young? When the person is 12 years. Okay, the person is 12 years. So that's why you remember Young's formula is equal to age divided by age plus 12 into adult dose. But similarly, you are having your Dilling's formula. Similarly, you are going to have your Dilling's formula. And Dilling's formula is nothing but age is equal the dose, child dose is equal to age divided by 20 into adult dose. Okay, now how to remember Dilling's formula? Simple thing, okay? This might be a bit funny, but you can remember it, okay? Just remember Dill. Dill means in Hindi it means heart, right? So when does a person starts to get feeling or the hormonal changes happens? When the person is going to be 20 years old, right? So remember Dilling's formula. Dilling's formula means heart. So when do you start giving heart to other people? When you are 20 years of age, right? Because before that you don't understand what is it, right? So age divided by 20 into adult dose is your Dilling's formula. And Young's formula, when are you young? 12. So age divided by age plus 12 into adult dose. So these two formulas which are there are very much important. And then based on body weight, okay? Based on body weight, you are having dose is equal to body weight in kgs divided by 70 into average adult dose. Okay, now how to remember the 70 is down? Average weight of a healthy human or a man is 70, right? The average I'm telling you, okay, not take a common one. The average if you take of a human population is going to be 70. So dose is equal to body weight in kg of the child divided by 70 into average adult dose. So these are the three formulas which are very much important for your examination. 100% true marker you are going to get. So these are the factors, the patient related factors. It's depending on the patient. Who is the patient, right? So depending on that, you are having your age rated and your body weight. Okay. Now next one is there that comes with the sex. Like whether the child or whether the patient who is there is a male patient or female patient. So based on the sex also, various drugs are going to have various actions. So the same, for example, if we talk about like CNS depressant drugs, okay, CNS depressant drugs, or if you talk about alcohol, okay, very simple, right? CNS depressant, one maybe example is there, alcohol. So the people, like the male, if you compare the male drinking capacity and the female drinking capacity, obviously it is different because of the hormonal level, the body structure, the hormone level is completely different. So the sex of the patient will also determine the drug action. The sex of the patient will also modify or will also affect the drug action. For example, alcohol, if you give if you take around comparatively for getting the sedation activity, you need to give more amount of alcohol to the male patient compared to female patient. The concentration of the alcohol has to be more in the case of males in compared to the females to get the same selective effect. That is because of the sex. Okay, that's a male or a female. Now similarly, an example is there, like beta blocker, you talk about quinine, you talk about diuretics. These drugs which are there, okay, these drugs which are there, they are responsible or they are going to decrease the libido behavior. Libido is nothing but the sexual behavior or sexual arousals. Okay, so the beta blocker, clonidine, diuretics are going to decrease the libido in the male patients. They are going to decrease the libido in the male patients. Okay, then next is the diet and the environmental factor. Okay, let's try to understand about the diet. How does the diet or how is diet going to modify the drug action? For example, let's talk about, we already discussed this, I'm just revising again, I'm telling you, we have already discussed this in pretty much detail, okay? So I'm just revising it again. So milk, if we talk about, what does milk consist? Milk consists of your calcium. Milk consists of your calcium. So, when the patient is taking tetracycline, when the patient is getting or when the patient is going to take tetracycline with calcium or when tetracycline is taken with the administration of the milk, then what is going to happen? The absorption of tetracycline inside the body is being decreased. The absorption will be decreased. Okay. Now for similarly, if you talk about fatty foods, okay, fatty foods if you are giving it with your riboflavin, when you are going to give it with riboflavin, which is nothing but an antifungal agent, okay? So when you are going to give a fatty food with riboflavin, which is an antifungal agent, then what is going to happen? It is going to increase the absorption. How milk is going to reduce the action rate or reduce the absorption of the drug? Similarly, the fatty food when it is given with riboflavin, it is going to increase the absorption, alright? So this is how the food which is there or a diet which is there going to affect the drug action. Okay? Now next one which is there is the cigarette smoking. It is the cigarette smoking. So cigarette smoking which is there, this is going to induce the hepatic microsomal. This is going to induce the hepatic microsomal enzymes. Okay, so the cigarette smoking which is there, okay, so cigarette smoking which is there, this is going to induce the hepatic microsomal enzyme. Okay, so because of that, what is going to happen? The metabolism of the drug, okay, the metabolism of the drug which is there, it will be increased. So if metabolism is increased, then what will happen? So instead of showing the action, the metabolism will be comparatively faster. So without showing the action, the drug will get metabolized. Okay, without showing the action, the drug will get metabolized. An example of such drugs are like your theophylline. The example of such drug, that is your theophylline. Okay, so I hope you have understood how the diet and the environmental factor of the patient is going to affect the drug action. Okay, now next I will talk about that is the genetic factor. Okay, already we have discussed the genetic factor also about the G6PD deficiency if you have understood, right? For example of such drugs are like your primaquine. So people or the patient who is going to have this G6PD deficiency, this enzyme deficiency, if you are going to administer the drug like your primaquine, then what is going to happen? It is going to induce your hemolysis. This is going to induce hemolysis, and this is called as primaquine induced hemolysis. Okay, so these are the genetic factors. So based on the genetics, what is going to happen? The patient who is there is going to have G6PD deficiency, and if the patient is going to have G6PD deficiency and you are going to administer the primaquine drug, then what is going to happen? This patient is going to have hemolysis. This patient is going to have hemolysis. There are various other genetic factors also, but in the exam point of view, if you write 1 or 2, it will be more than enough. Okay. Now, next we are going to understand a very interesting factor, that is the physiological factor of the patient. Okay. So a patient who is coming, it depends. What is the physiological state of the brain? Okay. Now, the example for this is called a placebo effect. It's derived from a Latin term. Okay. The patient which is there. This placebo effect is derived from a Latin word which means to please me. Okay, to please me. Now let's try to understand it with the example. Okay, we are having two patients, A and B, and both are suffering from pain. Both are suffering from pain. Okay. Now, if I am a doctor, I am going to give the patient. I am going to go to the patient A. I'm saying this for now. Yeah. I am going to go to the patient A, and I am going to ask. I am going to tell them. Let's see. This is a medication. Okay, this is a medication A. This is the medication A which is there. I'm going to give, and I'm going to give a full support to the patient. I'm going to tell that this medication which is there is number 1 medication. It's 100% responsible. It will be reducing your pain. You will be all fine. And I'm giving a proper counseling about that medication. Okay, but actually that's not a medication. What is it? It is just a sugar tablet which I'm giving it. It is just a sugar tablet which I'm going to give to the patient B. Similarly, I'm going to go to the patient B. I'm going to give medication B. Now this medication will be having morphine. So what is morphine? Morphine is an analgesic, right? Morphine which is there, something but an analgesic. So when I'm going to give morphine to the patient, like patient B, okay, in the medication B, I'm going to give morphine over there, okay, and I'm going to give the counseling like this is the worst medication, this won't work anyways, but it's okay, you can try if it works, okay, but I'm sure that this won't work. So I'm making him believe that the medication which is there won't work. I'm making him believe that the medication which is there won't work. But similarly, to patient A, I'm giving a medication which is just a sugar tablet. It is not a medication, it is just a sugar tablet, and I'm going to give it to the patient. So if you observe the results of it, it's a very interesting result is that the patient A, which was consuming sugar tablets, okay, the patient A which is going to take, consuming sugar tablets, had comparatively better effect. Okay, have better response was there. The pain was gone. The pain was gone for the patient A. But similarly, even after giving morphine, a strong analgesic, to the patient B, who was suffering from the pain, his pain did not relieve. His pain relief wasn't there. So this is nothing but the physiological factor of the patient. Okay, and this effect which is there, this is called as the placebo effect. This effect which is there is called as the placebo effect, and we usually use this to treat such subjective symptoms. What are the subjective symptoms? Such as your anxiety, tremor, and your pain. Okay, so very interesting this is. Okay, I hope you understood about the physiological factor. Okay, now next one which is there, that is the pathological factor. Okay, pathological factor means what? The patient, okay, pathological factor means you can just say it as comorbid conditions. You can just say it as comorbid conditions. Let's come and understand one by one. Okay, the first one which is over here is the GI disorder. This is the GI disorder. So in case of the patients, okay, in case of the patients who are having achlorohydria, that means no HCl. Okay, achlorohydria, or the patient, the stomach is not able to secrete much HCl. Now what will happen if you are administering the weakly acidic drugs? Okay, if you are going to administer the weakly acidic drugs, what will happen if the acid is not there? This will start to ionize. The weakly acidic drugs which are there, because there is no acid, these weakly acidic drugs which are there, they start to ionize, and because they are getting into ionized form, the absorption will be slower, or the absorption will not happen. Okay, and this will lead to the malabsorption. This will lead to the malabsorption. Okay, try to understand. In the GI disorder, if you are having a disorder such as achlorohydria, then HCl is not produced, and if you are going to administer weakly acidic drug, then what is going to happen? This weakly acidic drug is going to ionize, and if the drug is getting converted to ionized form, you already have known one of the major factor of drug absorption. If it is converted to ionized form, it is very difficult for the body to absorb that drug. So the absorption is impaired in the case of GI disorder. Okay. Now next one is here liver impairment or liver disorder. So patient who is having chronic liver disorder, what is going to happen over there? The drugs which are there, which are going to have higher first pass metabolism. Now metabolism won't happen, right? Because enzymes which are there, okay, the enzymes which are there because of chronic liver disease, the enzymes won't be functioning, liver is not functioning, enzyme won't be functioning. So for the drugs which are going to have higher first pass metabolism, so their first pass metabolism will not be happening. So if the first pass metabolism is not happening, what will happen? The concentration of the drug which is there will be more in the blood vessels. Okay, the concentration of the drug which is there will be more in this thing, and that will lead to the toxicity. That will lead to the drug toxicity, and that is called as your example of such drugs are your propranolol. Okay, so in the case of liver disease, what is going to happen? In the case of liver disease, what is going to happen? There is going to be decreased first pass metabolism, and because of that the drug concentration is going to increase, and this increase in drug concentration will lead to the drug toxicity. Okay, so I hope the liver disease pattern is clear. The last one which is over here, that is the renal failure. Now the patients in which the kidneys are damaged or the renal is not working properly, so certain drugs are there which are completely which are going to completely depend on liver for their excretion. Okay, so but if the liver is getting impaired, okay, the liver, if the kidney is going to get impaired, then what is going to happen over there? The drugs which are there will not be able to excrete, and that will lead to the nephrotoxicity. So the drugs such as your aminoglycosides, okay, drugs such as aminoglycosides, if you are giving these drugs to the patient who are going to have renal impairment, the excretion will be slower. So it is very important to adjust the dose. It is very important to adjust the dose of this such drugs for the patient who is going to have renal impairment. So these are the certain pathological factors which are going to modify the drug action. Okay, which are going to modify the drug action. Now one very important factor which is there, which we are going to discuss in the upcoming, is that what is tolerance? Okay, what are different types of tolerance? Again, a very important 2-marker and 5-marker question is there. And what is tolerance? What is different kind of tolerance? And how do we develop tolerance? Okay, it's a very important one because you have to understand this, because now almost if we talk about antibiotics and all the other drugs which are there, our body is getting tolerated, they are getting resistant. So just try to understand what are the different mechanisms, how the patient is going to develop the tolerance. Okay, so now we are going to discuss about the tolerance. Okay, one of the major patient factor which comes is tolerance. Okay, so what is actually tolerance? Tolerance means what? For example, you are going to give a particular drug. That drug, the concentration is reaching the site of action. Okay, but still the action which is there, the therapeutic activity which is there, the drug is not able to show. That means your body is well tolerated to the particular drug. Okay, so what is the mechanism of tolerance, that also we'll understand, and what are different types of tolerance, that also we'll try to understand. Okay, so majorly we are having 4 types of your tolerance. First one is your natural tolerance, then is your acquired tolerance, then cross tolerance, and then your tachyphylaxis. Okay, so what is natural tolerance? Natural tolerance means it is not been acquired, it's like naturally it is there in the body. That also we are dividing into 2 types. One is a species tolerance, related to species, and the other one is your racial tolerance. Now, if I talk about the species tolerance means what? Like for example, humans are there, rabbits are there, animals are there. Yes, no? So the some species of rabbits are there which are going to be highly, when we talk about rabbits, right, they are highly tolerated to atropine. So how much of atropine is you are going to inject that particular rabbit, it won't show any activity. Okay, that is what they say, that the rabbits, in fact, they feed on atropine. Okay, rabbits which are there, they're loving food, that is a Verona atropa, right? They're going to feed on the atropine, but still they won't have any particular activity of the atropine. But the same atropine, if it's taken by the humans, then the therapeutic activity is seen. And this is what is called as a species tolerance. The rabbit species which is there, it is well tolerated to this drug, that is your atropine. Okay, simple. Now next one is your racial tolerance. So based on the races, right, like non-Hispanic blacks, Americans, Indo-Asians, right. So the blacks which are there, okay, or the Nigerians or the blacks which are there, they are going to have well tolerated to the drugs which are going to call mydriasis. Okay, so let's see again what is mydriasis, what is meiosis. All these things you will understand in the upcoming chapter is your autonomic nervous system. Just try to understand the mechanism of tolerance or what is actually tolerance. Okay, so one is your species tolerance, other one is a racial tolerance. Based on the races of the person, the tolerance is developed. Okay, now these are the kind of natural tolerances. That means it is like naturally in the particular human it is there. Okay, but now if I talk about the acquired tolerance, okay, this is a very major one. As the acquired tolerance, what is acquired tolerance? When the patient, they are repeatedly going to administer the drug, after some time, okay, after a certain time, they are repeatedly administering the particular drug, the patient will get tolerated. Some such drugs, the example of such drugs are your morphine and your alcohol. Okay, so such drugs are your morphine and your alcohol. So even young age people who are there, starting when they drink alcohol, okay, so what happens? They will not be tolerated to alcohol. Okay, so even a small dose of alcohol will be able to. You will get the action, you will get the activity. But for example, like co-drinkers who are there, who goes to club parties every time, they can drink liters of alcohol without showing any activity, or they will be stable even after drinking liters of alcohol. Okay, that is what is called, after the repeated exposure, that thing is acquired. Okay, that the thing which is the tolerance which is there, it has been acquired. And such drugs which are there, which can be developed, the tolerance can be developed, is your morphine and your alcohol. Okay, as it's very simple. What is your natural tolerance? Acquired tolerance. Now, the next one which is there, it is the cross tolerance. So what is a cross tolerance? Now, for example, okay, Cross tolerance means, like for example, the drugs which are having closely related, like which are closely related in the case of their structure or their mechanism of action. Okay, those drugs which are closely related with the structure or mechanism of action. For example, your alcohol, ether, some opioids are there, some nitrates like mononitrate, dinitrate. So they are having pretty much similar structure and mechanism of action. Okay, so for example, if the patient is tolerated to alcohol, okay, the patient who is there, it is well tolerated to alcohol, then the same patient who is there will be tolerated to ether also. Okay, because they are structurally similar. Okay, they are going to be structurally similar. So because of one particular drug, okay, because of particular drug which is closely similar to the other drug, the patient is going to get the tolerance for the other drug. Even when it's first time they are exposing. For example, the patient is a regular drinker. Okay, he is regularly consuming alcohol. So he is getting tolerated to alcohol. But one day if you give ether also, ether will also have the same tolerance. That is because of similar structures. So some of the examples are your nitrates are there, opioids are there. There are some other examples of the cross tolerance. So because of one drug, there is a tolerance developed for the other drug which is going to have similar mechanism of action or similar structure or they are closely related. That is what is going to come under the cross tolerance. Okay, so I hope it is clear. Now next one is there. This is tachyphylaxis. Okay, already in statistics also you will have studied what is tachyphylaxis. So what is tachyphylaxis? It is nothing but that is when you are going to continuously administer the drug to the patient, there is going to be sudden decrease in the pharmacological action. Okay, the key word in this definition of tachyphylaxis is that there is a sudden decrease. It's not like a continuous decrease, slowly degrading. No, it's not like that. There is a sudden decrease in the pharmacological activity. So example for this is nothing but a triamine and ephedrine. Okay, so these drugs after the repeated administration, there is going to be a sudden and rapid decrease in the pharmacological action. This is what is coming under the tachyphylaxis. An example of these drugs are here triamine and ephedrine. So I hope tolerance is, you have understood what is tolerance and you have understood what are different types of tolerance: natural, acquired, cross tolerance and tachyphylaxis. But now we have to understand how was this tolerance developed. We understood what are types of tolerance, but now we should understand what are the mechanism of this tolerance. How is this tolerance developed by a particular body? Okay, so in that mechanism we are dividing it into two. One is here pharmacokinetic tolerance and other one is here pharmacodynamic tolerance. Okay, so what is going to happen in pharmacokinetics? Kinetics means what? ADME, absorption, distribution, metabolism, elimination. So what is pharmacokinetic tolerance? That means the concentration of the drug, there is going to be decrease in the concentration of the drug at the site of action. Now, why is there a decrease in the concentration of the drug at site of action? Because when you are repeatedly going to administer the drug, try to understand, when you are going to repeatedly administer the drug, the body which is there, it might decrease the absorption, increase the metabolism and increase the excretion. Okay, so pharmacokinetic tolerance means what? It is going to decrease the drug concentration at the site of action. And why is there a decrease in drug concentration? Because the absorption has been decreased, metabolism has been increased and excretion has been increased. So because of that, drug is getting excreted out. So other than showing the pharmacological action, it is being excreted out. One of such example is here rifampicin and oral corticosteroids. Oral contraceptives. Okay. So if you talk about rifampicin drug, right? This rifampicin drug is going to affect or it's going to channelize your metabolizing enzyme. It's going to induce the metabolism enzyme or it's going to induce the enzyme which is responsible for the metabolism of oral contraceptive. Okay, rifampicin is going to induce the metabolizing enzyme which is responsible for metabolism of oral contraceptive. So we are going rifampicin and oral contraceptive together. What will happen? Rifampicin will activate the enzyme for the metabolizing the oral contraceptive. So without showing the contraception, the oral contraceptive will be excreted or will be metabolized and will be excreted, and this will lead to the contraceptive failure. Why is there contraceptive failure? Because rifampicin is going to induce the enzyme or the hepatic enzyme which is responsible for the metabolism of the oral contraceptive. Okay, this is coming under the aspect of your pharmacokinetic tolerance. tolerance. This is coming under pharmacokinetic tolerance. Okay. The next one which is there, that is the pharmacodynamic tolerance. Okay. So what is this pharmacodynamic tolerance over here? Pharmacodynamic tolerance means that the receptor mechanism which is there, already we have studied different types of receptor families, right? So there is going to be, when there is a continuous administration of the drug, this will lead to the down regulation of the receptors. This will lead to the down regulation of the receptor. And because of the down regulation, what will happen? Even when the drug is reaching the site, it won't be able to show the action because the receptors which are there, they are going to get down regulated. So I hope you have understood what is the mechanism of development of tolerance. Okay, so this was all about the tolerance part. Okay, so this was all about the pharmacodynamic aspect we have understood. Okay, so there is one small topic which is called as your pharmacodynamic and pharmacokinetic interactions. What different types of interactions are there? That we'll be discussing. Maybe I'll just leave a small video later. Okay, so this was all for today. We have discussed about the different types. What are the different patient factors we have to talk about? Drug factors which are going to modify the drug action. Okay, this is all for today. Thank you everyone for watching us. Keep supporting, keep liking us. A small video of interactions will be released very soon. Maybe it'll just go for 5-10 minutes. We'll release it very soon. And next we are coming up with a very interesting chapter. This is the autonomic nervous system, and we are really happy to announce that after finishing the Journal Pharmacology, 8 lectures of Journal Pharmacology, because see, we took this time because it is very important for you to understand the basics. Okay, now if you have understood the basics, now we'll be going on to the very advanced topics like your autonomic nervous system, followed by cardiovascular, followed by central nervous system, and let's continue the journey. Keep supporting us. Join our Telegram channel for the notes. Thank you everyone. Signing off for the today.